morning.
How are you?
All right, and yourself?
I am well. I'm well. How was your holiday?
It was nice and quiet, and I'm glad the week is over. How about yours?
Yes. Um, it was relatively quiet. It was rainy a little bit. It was quiet until I ran into one of my friends who celebrates a birthday on the 4th of July, and she's been celebrating all week. And I've been right there with her all week. So it's been fun. And then
Okay.
she goes out with the red, white, and blue theme because, of course, you can find it everywhere. And so it's been red, white, and blue palooza around here, these streets. So it's been fun. It's been good. It's been good. I tried to get some rest, a little bit, just a little bit. But
Okay.
other than that, it's been good. Okay. Good morning. Good morning, Tanika. Good morning, Miss Carolyn. Good morning. Good morning. But other than that, it's been real good. It's been real good.
Good.
It's been interesting, I'll say that. Uh oh. Wow. Okay. I was reading stuff from my friends at the AMA. They be on one. But I love it. I love it.
Good.
All right, well let's get started. Welcome everybody to the Saturday morning tea where we discuss health information news, education, certification tips, entrepreneurship, the holidays and birthdays and all of that, and the revenue cycle at large. As you come in, don't forget to hit the thumbs up or like button. I'm Clarice Warner. I'm the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, the heart of it all, that specializes in revenue cycle and regulatory compliance in education. But let me ask you, do you know what it takes to be a certified marketable medical coder? Do you? Do you really? Well, before I introduce my co host, let me share with you information on a free, yes, free 99 email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. I just had on that hat a couple weeks ago. Let me get my hat back together. Okay. If you are interested in getting more information about the 5 steps to become a certified marketable medical coder, then check out the video description for the link. So, joining me today and every Saturday is my illustrious co host, Mr. Jesse, the registered trademark. Put some respect on his name because they're not like us, the coding nerds. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I have been in healthcare for a mighty long time in nursing. 2014, I left the bedside and started working in HIM. And in 2020, during the pandemic, I created a company, the Coding Nurse LLC, where I help nurses and other people in healthcare with a clinical background transition into the wonderful world of HIM.
Well, you hit my spirit with that mighty long time, sir. I was about to go into deep song, a mighty long time. All right. And how are things working out for you?
It's coming along. There's not enough time to do everything you need to do.
No, say that again. Say it loud for the people in the back. Good Lord. Every day I start with a list, and every day there are things that fall off that list and have to go on to the next day's list. Every day. It's like, wow, we run out of time to get
Yes,
it all in. But yeah, we gotta do what we gotta do, right? Right. Okay.
absolutely.
So before we jump in, let me remind you that you can join in and add to the conversation. Again, we bring the topics, we bring we set the table and we invite everybody to come in and sit. How about that? So don't be shy. Your opinion matters and is welcomed here. Friends, you can use the chat. Place all your comments. Y'all know what to do. Place all your comments in the chat. We will definitely respond. Comments, questions. Now, if you have a question, please type Q first so that we know that it is a question for us and we don't miss it. And I know sometimes y'all be talking amongst yourselves and all of the things, and we just look while we talking, we eyeballing y'all too. We in everybody's conversations. We just ear hustling, eye hustling. We doing all the hustling over here. So feel free to talk, govern yourselves accordingly and talk among yourselves if necessary. All right. So, for those who are joining us or watching the replay, today we are talking pair tactics, coding guidelines versus clinical validation. Boy, these folks out here, these streets are just running amok. I'll say that.
Aren't they? That is very well said, because that's what it is. And can I? I'm just so over it.
What's a person to do? At this point, I'm like, wait a minute. Uh-oh. Carolyn hit you with the Spanish. Hold on.
Ah,
Oh, I see you responded
ah.
back. See, y'all playing. Y'all playing. See, I ain't even get to see what happens in the chat. Good morning to our on the street correspondent, the crappy coder. Good morning. Oh my goodness. All right. Y'all have tickled me. But first, before we get into all of the foolishness that we got going on here, let's uh open up for church announcements, shall we? Shall we? Doo-doo. Actually, today I really don't. Uh-oh, wait a minute. Oh, wait. And just as I was turning, the spirit moved. Hold the press. Wait a minute. Do I need to turn it back up? Because the spirit that moved, y'all. When the spirit moves, we got to follow suit. Oh my God. He went into a full clap mode.
Yes.
Yes. See, sometimes it just gets down in there, sits in that spirit. Yes. Okay. Well, the only church announcement I have today, I guess, is that earlier, I guess it was a couple weeks ago, I know I talked about the ICD-10 PCS codes were released as well as the guidelines. Well, the ICD-10 CM guideline information has also been released. I'm I'm going through it. I don't see a whole unless I'm going through it and I don't see a lot of changes. I see a lot of shifting and shuffling of titles in the guidelines, but not, a lot of new stuff. And maybe I haven't gotten far enough to find where the new stuff is, but I'm not seeing a whole bunch. And the way you can determine whether or not something is newly added to the guidelines is that it's printed in bold. It's bold in that current year, or that year that the fiscal year that guideline is taking in effect. So still going through that to see if there's something of significance that folks need to be mindful of. But I'm not saying a whole lot. But really, that's all I got. Mr. Jesse, you have anything in the church announcement?
Well, when it comes to these codes, I'm glad that it's kind of quiet because for the past couple of years, it has been some major changes.
Yes. Yes.
I guess they like, look, we tired.
Tired, boss. We tired. I haven't checked the codes, so I don't know what is changing or being added or deleted as it relates to the ICD-10 codes. Um, so there may be some. Of course, there probably will be some movement on that. Oh. The um, coordination and maintenance meetings that they have. There's one coming up in September, and I believe they will be opening up for registration soon. So if that's something that interests you, where you can get information on the new ICD-10 as well as ICD-10-CM as well as the ICD-10 PCS codes that are being proposed into the manuals for, I think these codes will probably go into, they're either April or October of the following year. So they are like a year ahead. But you get all the information about the why this code is needed. If it's a procedure, you have the practitioners who actually are using these procedures or performing these procedures give you kind of a rundown of what that looks like. It's really a good time had by all. Plus, it's free CEUs, free 99 CEUs. I think you get free CEUs for the live as well as for watching the replay. So I guess I did have a church announcement. Go ahead.
I do have. It's really more so like something like FYI. Like I really think that we have to. What I'm interested in seeing is because I'm sure everybody has heard. Like last week, everybody was all up in a tizzy about the Supreme Court ruling with the Chevron. Mm-hmm. So what I'm interested in is not so much HIPAA because HIPAA was passed by Congress.
Right.
So that's kind of set in stone. But I'm thinking about all of the regulations that CMS has. What is stopping these, payers from getting together and trying to challenge them and push back? And if the regulatory agencies have lost their power or their power is weakened to enforce rules, that could really create a whole lot of chaos in healthcare, more so than what it already is.
Mm-hmm. So I normally don't advertise other folks' stuff on my platform unless there were some coins involved, and that's the way of the world. However, since you mentioned that, this week on, I don't know if you all are familiar with Talk 10 Tuesdays, they have a weekly podcast that you can listen to it live, but then you can also go back and catch the replay. I think they're on all the podcast platforms, but they are going to talk about, in deference to HIM, the Chevron Explained. So they're going to, I guess, do a deeper dive. Another place to find additional information. Y'all know I love the law, so I'm always on healthcare lawyers, listservs and such. I think Holland and Knight is one that I look at all the time that provides a lot of information. So I would also encourage to kind of check out some of those sites, particularly if they are in the compliance space, the healthcare compliance space or healthcare, that gives you a slant from our perspective on, what we should be looking for or what we should be paying attention to. So there are a couple places that that you can get some information. And maybe that will be our topic for next week. Look, we got it early. Maybe that'll be our topic for next week. Kind of, let's hear from the attorneys and those experts have to say on how it impacts us and what we do. So maybe we will have that as our topic next week. So be prepared. Come to the table prepared. Don't come empty-handed. How about that? Any other announcements from the people? Let's see what's going on out here. Everybody talking. Yes, I listen to them all the time. Okay. Yeah, she listens to them all the time. Okay. All right. Well, let's get into what we got going on here. All right. So, um, again, for those who are joining us and watching the replay, we will begin spilling the tea on payer tactics, coding guidelines versus clinical validation. And so last week we talked a little bit, or a lot of bit, if you will, about the differences between DRG validation and clinical validation, and how in some instances hairs are being split and um, lines are being drawn in the sand on the requirements for the folks to do whichever type of validation they're choosing to do. So this week we want to focus on um, pretty much from the payer perspective, specifically um, the Medicare Advantage payers. And all I could think of is audacity. Just like we're not like y'all. That's I feel like that's what they saying. We're not like y'all. So we don't have to follow the rules. We don't have to pay attention. We kind of just can do our own thing. And I mean, I don't know, what is it going to take for them to understand what is CMS and all of the folks going to have to do to make them understand? Yes, you are just like us. You're part of us. You're not special. You're not different. So, um, in the description, I put the link to an article by Brian Murphy. This is Payers Turning to Clinical Validation to Ignore Coding Guidelines and Deny Claims. And I think he has a podcast as well. So I think this is probably, maybe, possibly um, on his podcast. He said that, and we know this, that clinical validation audits are on the rise among the chief causes of claim denials. And he had a guest, Rochelle Martin, who has a whole bunch of alphabets behind her name. But, or Rochelle, I'm sorry. She is a JD, and she's over here in our health information world. She has an RHIA. She is certified. She has CPC, and some additional AAPC credentials. Um, and what they're saying is that the Medicare Advantage organizations are just really off the chain. Uh, and they're causing more of these claim denials that everybody are seeing currently. Um, and one of the things that they're doing, they are ignoring guidelines for reporting additional diagnoses. And uh, in this article, they talked about the, and we're going to actually go through and look at the guidelines. The addition of the clinically significant conditions, and that language was actually added for our current year guidelines. So that was new, and for this year, and it's still valid up until September 30th, 2024. But it seems, or it appears, that the Medicare Advantage folks have been playing with the church's money, as Mr. Jesse liked to say, playing with the guidelines related to that, and so they are um, kind of using that to their advantage and creating their own criteria around it and or definitions, or pretty much just ignoring stuff that are clearly in the guidelines. um, some of the conditions that have been targeted are favored. We see all the time: sepsis, acute respiratory failure, hyponatremia, uh, acute kidney injury, severe protein calorie malnutrition, um, etc. So, yeah, it's all around. Most of this denial foolishness from Medicare Advantage is really stemming, or the increase in the denials that we're seeing from Medicare Advantage is really stemmed a lot from just them adding clinically significant to the official guidelines. Mr. Jester, did you want to weigh in before I take a look at the actual guidelines themselves?
What I'm kind of what kind of struck me as odd is like how I just how them adding the clinically significant has caused such a ruckus when everything you code or every diagnosis captured should that they use the acronym MEAT. So anything you code should be clinically significant anyway. That's why you're coding it. So I'm not understanding any of it, to be honest.
Okay, so let me let me share the screen. Okay, so all of this is really around section 3, reporting additional diagnoses in the official ICD 10 CM coding guidelines. Um, and so these are the general rules for other or additional diagnoses. And it says for reporting purposes, the definition of, quote, other diagnoses is interpreted as additional clinically significant. You see, it's bold. That's why that means it was new for this year. Conditions that affect patient care in terms of requiring clinical evaluation or therapeutic treatment or diagnostic procedures or extended length of hospital stay or increased nursing care and or monitoring. So in the UHDDS, item number 11/B defines other diagnoses as all conditions that coexist at the time of admission that develop subsequently or that affect the treatment received and or the length of stay. Diagnoses that relate to an earlier episode which have no bearing on the current hospital stay are to be excluded. UHDD, UHDDS definitions apply to inpatients in acute care, short term, long term care, and psychiatric hospital settings. The UHDDS definitions are used by acute care short term hospitals to report inpatient data elements in a standardized manner. These data elements and their definitions can be found in the July 31st, 1985 Federal Register. Since that time, the application of the UHDDS definitions has been expanded to include all non outpatient settings, so acute care, short term care, long term care, and psychiatric hospitals, home health agencies, rehab facilities, nursing homes, etc. The UHDDS definitions also apply to hospice services with all levels of care. So the following guidelines are to be applied in designating, quote, other diagnoses, end quote, when neither the alphabetic index nor the tabular list in ICD 10 CM provide direction. Note that those areas come first. You get your guidance initially from your coding manual. The listing of the diagnoses in the patient record is the responsibility of the provider. So you have these three areas. You have previous conditions. If the provider has included a diagnosis in the final diagnostic statement, such as the discharge summary or the face sheet, it should ordinarily be coded. Some providers include in the diagnostic statement resolved conditions or diagnoses and status post procedures from previous admissions that have no bearing on the current stay. Such conditions are not to be reported and are coded only if required by hospital policy. However, history codes from category Z80 through Z87, may be used as secondary codes if the historical condition or family history has an impact on current care or influences treatment. Next, you have abnormal findings. Abnormal findings, laboratory, x ray, pathologic, and other diagnostic results are not coded and reported unless the provider indicates their clinical significance. If the findings are outside the normal range and the provider has ordered other tests to evaluate the condition or prescribe treatment, it is appropriate to ask the provider whether the abnormal finding should be added. Please note, this differs from the coding practices in the outpatient setting for coding encounters for diagnostic tests that have been interpreted by a provider. And then the last section here is uncertain diagnoses, or the last point. If the diagnosis documented at the time of discharge is qualified as, quote, probable, suspected, likely, questionable, possible, or still to be ruled out, compatible with, consistent with, or other similar terms indicating uncertainty, code the condition as if it existed or was established. The basis for these guidelines are the diagnostic workup, arrangements for further workup or observation, and initial therapeutic approach that correspond most closely with the established diagnosis. Note, this guideline is applicable only to inpatient admissions to short term, acute, long term care, and psychiatric hospitals. So, all of the stuff that is not voted, which is the majority of this guideline, has been the same forever, except for this little clinically significant. So, it appears, again, based on the word on the street, Medicare Advantage folks are trying to determine basically what they feel would be considered clinically um, significant conditions um, in the claims that they're receiving and or the medical records that they're receiving. Again, prayerfully, folks are not. I don't know how to. I know I would see this a lot on the pro fee side and outpatient side, where again I've talked about this, where they have allowed the electronic medical record to ele- take the problem list and insert the problem list into the assessment, or insert the problem list into that current encounter. Hopefully they are turning that off and stopping that, because that's running amok and causing all kinds of problems, especially if they're not um if the person is not, and again I'm only speaking on the outpatient piece of it, or pro fee piece. If that patient is not being seen, or none of those problems are being addressed, then you have these diagnoses codes that are in this assessment that are automatically populated, that the doctor, there's no reference of it in the note, there's nothing. But then all of the stuff is coming on the bill, all the stuff is being interpreted as um, something that, quote unquote, has some meat added to it, but there's no documentation to support that. And I know I have for years been an advocate of turn that foolishness off, because um oh Lord, oh, it's a mess. Turn it off. Now I don't know if that's something that lives in the inpatient world as well, I mean, I know they have, problem lists. I don't know if that automatic adding it to
They do.
it I think to me, I think that's one of the solutions to some of this foolishness. They need to stop that. But go ahead. I'm sorry. Let me get off my soapbox.
Well, that's what when I started talking about the pro fee, that's why I was shaking my head no, because they still, but I don't even really think that yes, it's a problem, but at the same time, it still goes back to, was the condition monitored, evaluated, assessed, or treated? It all comes back to that. Like people make this way harder than it needs to be.
Right. But somebody is not paying attention. Well, that's a whole other conversation too, and I'll get to that in a minute. When they're just pushing this stuff out to validate, hey, did did they assess this? Because if it's automatically showing up, all they're doing in most cases, because of productivity and all of the things that are on their back, we just pushing these out. Oh, we see all of this was in the assessment. Okay, well, this must have been done. No, people aren't doing the appropriateness and due diligence as it relates to coding to validate that that documentation supports all of the stuff that's in that assessment. And because of that, and other things that play into that, like productivity, like, you know, we need to drop these claims in X amount of days, all of those things are falling through the cracks. And unfortunately, they're hitting these payers, and these payers are being a little more sophisticated, if I guess, if you will, and maybe they have their own AI for first pass or whatever, saying, nope, this ain't it, this ain't it, and so they're denying all of this stuff. So folks on the provider side, everybody in their feelings, but I feel like this could all be so simple if everybody was doing their job. If your provider was documenting what they were supposed to document it based on that encounter with that patient, only those things that they assessed, treated, monitored, evaluated, the B. If the coder, d- he or she did their job in evaluating the documentation that was presented for them before the codes are assigned, etc., all those things, I think some of this, if this was all taken care of on the front end, this back end stuff would be minimized, in my
But
opinion.
they don't do it though, and
Nobody is doing, and I don't know why. Why?
well,
Is it because of all these other things that are in the background that's on
no,
their back?
because really and true, like the only reason they put clinically significant in there was because they were trying to emphasize, because that guideline. I mean, I've been teaching that. I have a whole presentation in my class on meat, and I use that exact section as a reference.
Yeah, this guideline has been here forever.
Exactly, and they put the clinically significant in there because that's the emphasis, that it has to be current.
Hmm.
That's really all that is for. Because I'm telling you, the problem with Medicare Advantage. With Medicare Advantage, there are so many codes that risk adjust, and a lot of them are chronic conditions.
Hmm.
So, very few providers are going to ever document a chronic condition in an inpatient setting because it's not relevant.
Okay.
Honestly, if somebody is in, let's say the person has AFib, the provider, I have never ever seen a provider document left ventricular hypertrophy, but it will be in the echo that they copy and paste into that note. So that's how these Medicare Advantage programs have been basically gaming the system, because because the providers do not document the conditions because they don't really assess it. And I've been saying this since 2018 when I was working in risk adjustment. Like, do you have these, like for instance, like, because the echo will tell you a whole lot, and there's a whole lot of risk adjustable codes in echoes, but I have never seen a provider read an echo. The only thing that they might mention from an echo is somebody's ejection fraction, but
Hmm.
they don't really. and pulmonary hypertension, they will document that. But like if somebody has like aortic, if their aortic root is dilated, that is a risk adjustable code.
Mm-hmm.
I have yet to see a provider document somebody with aortic ectasia. That never happens. But it is in the note. It is in the echo report. But you, as you know, as a coder, you're not allowed to code from diagnostic reports. But they do it. That's that's the problem, because if it's not documented, then how is it clinically significant? For real, for real.
Mm. I don't. I don't. I don't. I don't understand. Even on the outpatient um, side of the guidelines, they even tell you, um, even when if it's chronic conditions or chronic diseases treated on an ongoing basis may be coded and reported as many times as the patient receives treatment and care for the condition. You don't just slap them on there because they have them. They have to treat them. They have to.
But that's what they do. That's the problem. They've been doing it forever.
So who is not telling these? Again, this goes back to provider documentation. Who is not telling them the appropriate what is necessary for their documentation? I don't understand. And why? So inpatient, outpatient, even the CDI people, are y'all not telling them, look, if y'all not treating this, or are they not having these education sessions with the providers to help them? I mean, I know it's mostly case by case conversations based on whatever you're reviewing and validating at that time, but do they not have like an overview? Hey, let's just talk documentation in general. Stop. Only document what you're assessing. Only document the information or the diagnosis based on that. Or they and to me it's very very clear that this happens even with the problem with cancers, where the majority of the stuff that they've been seeing in the data that from the reports that from audits that have occurred, it's telling you over and over and over again, this cancer does not exist. There is nothing that has been proven for this cancer to be coded for this encounter during this date because it's a history. It does nothing. They're not treating it. They're not doing anything to it. So why are they still doing this? Why isn't there some kind of conversation? I know there's a lot of providers that really feel gung ho to be over in the health information space and want to be coders or want to read the. But why can't y'all stay in y'all lane and discuss appropriate documentation? Because I think that's your job. Your job is to assess these patients, treat these patients, take care of these patients, but also document the care for these patients. Um, I don't know. I don't know. Oh, and then there's another guideline that tells you to call all documented conditions that coexist at the time of the encounter or visit and that require or affect patient care, treatment, or management. Do not code conditions that were previously treated and no longer exist, which is the same thing over in the inpatient side of the world. However, history codes, and we talked about that, may be used as secondary codes if the historical condition or family history has an impact on current care or influences treatment. I'm confused. Like this this is I don't know. Somebody help me.
Well, I have said it before, and I'll just say it again. The problem is nobody wants to hold these physicians accountable. That's it. That is it. They do whatever, and the crafty coder, like the first comment, like first of all, coders don't even talk. And inpatient coders don't even talk to doctors. It's usually CDI to have the conversations.
Right.
And when you have when you first of all when you have CDI who don't know coding, How they even they don't like that's the problem. Like it is so much deeper than what people are willing to admit. And the reason why people are not willing to admit it is because it is going to go against the paradigm that has been set up. Because they have put these people in CDI on a pedestal that they know more than coders, and they don't when it comes to, because at the end of the day, when Medicare denies a claim, they don't say, "Oh, well, the nurse coded it." Well, the nurse, the CDI said it was okay. If it does not meet the criteria, it doesn't get paid, and that's their right. How could and none of this is about holding people accountable, because then they do all this knee jerk stuff as a response, but they never address the root issue. And I can tell you, be working in inpatient CDI, they're worried about the big fish. They don't give a. They say that they care about HCCs, but they really don't. They are chasing MCCs, CCs, and that DRG.
And that's fine. But you still find the same issues in chasing those. And but you're not addressing them.
Because it all comes down to documentation.
Exactly.
Because, like, case in point, like I brought this to my manager's attention earlier this week. I had a a record. This patient was diagnosed with sepsis. The person did not have one clinical criteria for sepsis. They you have to have two. You have to have SIRS criteria. You have to have two of four parameters, and they have an extra two just in case.
Hmm.
So they said the person had leukocytosis. Their white blood count was 10.5. That is not leukocytosis. Plus, for SIRS criteria, your white blood count has to be above 12. So the attending co-signed this note. So that meant that they're saying that this person has this. So I had to send a clinical validation query. The attending responds back that sepsis was valid. And I asked them to indicate clinical criteria, relevant clinical indicators. All they did was wrote in their note that sepsis was valid, did not put in any clinical criteria. I send the notice, I send the case number and the description to my manager, and until these facilities say, if you are not providing clinical, if you're not providing the adequate criteria, we're not going to bill it, it's never going to stop.
So until they doors get shut down because they can't financially sustain what is happening. I mean,
Well, well, I'm going to tell you what my this is how it is in my opinion. And my so what's going to end up happening in that case is it's going to go out as sepsis, but if it ever gets validated or audited on the back end, and one of the Medicare auditors say no, this was not sepsis, and they cut down the payment and then hit them with a bill, then they're going to come back to, you know well, what did CDI or coding miss? And it's not, no. When you have a query and this person clearly, because at that point, like I mean, I washed my hands of it. I did, my job is done.
you done your part.
Right. You,
Exactly.
no, I asked you. You said it is. Now it's between you and the insurance company.
It's you and other people.
That has
Exactly. We
nothing to do
tried to
with it.
save your we tried to save
Right.
you from the front end, but no. And so even on the back end, I know we have these revenue integrity departments. You have denials management departments. You have all of these other folks that kind of do what CDI does, but just on the back end. So they're going in and they're doing the validation and they're trying to and these departments aren't new. They're relatively new, I guess, but they're not new. They've been around for at least 5, 6 years.
But,
At
but
what point I know they got enough data to say, okay, we see Dr. Jones right here seems to be a problem. We are seeing the same thing over and over and over again. Part of all of this validation, part of all of this uh documentation review. Part of all of this, there is an education component. And why are folks not educating these providers?
There's no. It's not that they're not educating. There's no accountability. That's the issue. It's not education. It's accountability.
So they're providing this education, but it's like, well, I did my part. I told you. Now it's up to you. Which continue, and they're like 10 toes down. I don't care what you said. I'm
Because
gonna still do what I do. Da 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 da. And so this is a crazy cycle. That why
and
get
I've
rid of that. If you can't do your job, then you need to go.
but they never do that. Like they're like at the hospital where I work, we have a hospice physician who is ridiculous. When I tell you, he just pulls diagnoses out of his left pocket. No kind of validation, no nothing. So because he documents it, you can't ignore it. So you have to send these queries to the provider for them. They do a diagnosis status query. So and we ask the provider, do they agree? Do they not agree? Is it like they have options? So they have a whole dossier on this particular provider. They supposedly spoke to their quote unquote physician advisor about him, but there's been no change. It no His documentation is still the exact same. So when you have so at some point the C-suite has to get involved and say, sir, ma'am.
Somebody, yes, like you are a
But
risk. You are a risk. You are unnecessary risk to this organization because you refuse to do. You've been provided with the information. You've been provided with the education. We've shown you clearly over and over and over again. At some point, somebody needs to put the they pull the big panties up and say, "Hey, sir, ma'am, you got 30 days to clean this up. You got 15 days, or hit some folks in their pocket or something. I don't know, but
but
at some point, somebody got to make them responsible for their documentation.
but I have to also say there are people who do, but when they do, they get cast to that they get thrown aside. That they become targets in the organization,
Mm-hmm.
and people either leave or they get terminated, and
Or
more of
they
it.
become whistleblowers. Keep playing.
Right.
Keep playing. All of y'all, keep playing. Because the case is setting itself. The case is right there. All these people done seen and got eyes on this stuff. The cases are right there. Where
Right.
my
And
whistle?
but
Like,
but to Carolyn's point, it says we live in a litigious world. Providers need to document like documentation will be subpoenaed. It should be, but when I tell you, not there are most cases that really could be taken to court. They don't. It's not. It's people act like it's millions and millions of lawsuits. It's really not. And then even the ones that are, they usually settle. They don't. I mean, it's not. They don't have these long, protracted cases and all of this that goes on because it doesn't. It's just the system is too big. And what a lot of these facilities know is they know that Medicare can't catch everybody, so they take their chances.
yeah. Okay, I'm trying to show all your. Says those denials are never seen on the front end unless it's a big money item. Then front end will see it happen all the time at Nemours. Am I saying that right? Shaking my head. They should, Carolyn, but the fact it hasn't been subpoenaed yet, that provider feel like it can't happen to them. I don't understand. Yes, Jesse, I've been a target plenty of times, but I ain't changing my stance. And if it get crazy, I be out. Just never mind. It's like Clarice said, keep playing and find out. Right, right. Ridiculous. Has anyone had to deal with the IDR and No Surprise Act? Have you all had
I haven't.
run into any of that? I'm
I
waiting.
haven't.
Okay. Okay. I don't know. I don't understand. Like I said, I feel like it could all be so simple if everybody would stay in their lane and do their job and do what they need to do. And even bigger than that, um, the folks, the managers or directors or whomever, C-suite folks would also take a stance and hold folks accountable to do their job that they were hired to do.
But people, when your main concern is keeping your job versus doing your job, that's a problem.
Well, you done said a mouthful there, sir. That right there will preach.
Exactly.
That will preach. But this is again what's wrong with healthcare. This
Oh,
is the side
exactly.
of it of what is actually wrong with healthcare. And unfortunately, as a result of all of this foolishness, our patients are the targets. Our patients are the ones that if this gets denied, that ultimately they may have to come out of pocket and pay for something else, or then they have to go and can't get insurance because stuff that's documented isn't documented the way it's supposed to be, so on and so forth. So ultimately, our most valuable commodity, which is our patients, are the ones that are being harmed by this.
Well, and then another thing I wanted to mention before we move on is like you had talked about people doing their job and they have, all these other departments who are supposed to catch these things. You know what a lot of people don't realize is a lot of these higher level people are also offshore.
Oh my god.
So there's a whole, when I tell you it is a fool behind the scenes, it is a fool. And I am so thankful that I work in CDI on the inpatient side because I would have never seen it otherwise, ever.
Mm.
When I tell you, it's something. It is really something to see.
And Carolyn, I'm not suggesting that it's the coder's job um to enforce a provider to document, but I do think it's the coder's job to uh make recommendations to those who have the responsibility to have those conversations with the provider.
Because it's the hospital's job to enforce a provider to document.
Correct.
It's not a department. It is upper management. They're those C-suite people are supposed to make them do it. All
Correct.
these people that have all these MDs and DOs behind their name and they wear suits to work, it's their job to do it. But they're supposed to know the long-term ramifications if it doesn't get done properly.
I think that's also a there's a compliance element here too. I won't bore y'all with all of that, but I feel like there's a compliance element
But it's like, but I
here
tell
as
you all the
well.
time, like every time
But you
we
said every all these places don't have a robust compliance department, and that's
no, that's why
unfortunate
it all
because
goes
they are
on.
sitting right in the dab middle of all of this foolishness. They have arms in all of these areas. So if the coder somebody sees something and they're saying something, then that information needs to go and be investigated and then determined. And all the players need to have a conversation ultimately to the person who is causing the problems, because again it's only going to take one huge multi-million dollar issue that could potentially shut some of these places down. Yeah, these facilities are already nervous about revenue. They've been talking about it forever. Or at least for the last couple of years, I'll say that. Revenues is an issue. So they trying to figure out how to rob Peter to pay Paul to keep the doors open and da 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 da. When really look, you got don't look outside, look inside. Look at the people who are doing the documenting. Look, do that work. Maybe you could save a couple of coins in making sure that folks do their job in documenting so you don't have these issues. Because again, you are presenting the case for Medicare Advantage. You are presenting the case for CMS. You are presenting the case for the OIG based on what the documentation that you have going out the door. And if nobody is seeing that or nobody is saying anything about that or addressing that, that's a problem. That's a problem. And you are at risk. Your organization, the dollars, all of that is at risk. And why? Because nobody wants to have the conversation with the provider that, sir, ma'am, if you don't document this right, maybe this organization isn't for you. And why should we put all of what we got going on the line for one person who can't get right, who can't seem to
Right.
get it right? Why? Because they bring in a certain type of patient. That's another issue. That's another compliance issue. Or because hey, they bring in a certain amount of procedures or a certain amount of RVU or whatever. That's another issue. So all of this is tied. But folks, it starts with the little bitty thing of documentation, which actually explodes into bigger issues and has tentacles everywhere. Right, Jesse? Job scared. Get them every time. I understand the scared essential, but it just doesn't help this. In the hospital setting, they don't have to force it. In the outpatient world, though, it's a whole different thing, and we do have that responsibility. And no, we don't get paid enough sometimes. Yeah, unfortunately, in the outpatient, so you got some layers between the coder and the provider on the inpatient side. On the outpatient side, depending on the size of that organization, you don't. You and that doctor probably touching elbows on a regular basis where you can possibly have a conversation. But then my concern, again, even with the coders, is we already know we are fighting. We have our own internal fight. We have the fight against potential offshoring. We have the fight against even potential outsourcing. And we got the fight against the potential of AI. And we've always already talked about the need to potentially pivot what it is we do. If y'all can't stand on the skill of being able to have a conversation with somebody because y'all scared to talk to a physician, y'all gonna be in a world of hurt. Let me just say that. Can I say it that way? You're gonna be in a world of hurt if you can't have a conversation. And I know from years and years, I've witnessed it myself. And when I tell you my jaw dropped to the floor, that this woman that I've seen, I mean, know her stuff, do her stuff, was an auditor, but let a physician come into the room. She starts stuttering and just revered the fact that that person had on a white coat. And I'm like, ma'am, you put your pants on the one leg at a time, just like that person does. And your job here is to help them. So having the conversation and telling them is helping them do their job. Now, what they do with the information, that's further on down the line. But your job is to have the conversation, and you can't even have a conversation. You know your stuff. Your stuff is well documented, but you sometimes it takes a conversation. Hey, did you read my email about so and so and so? Because I'm not. I don't know whether or not you got it or you understood or whatever. Just in casual conversation. But she was so, oh, the doctor's walking through the door and we got to change up the what. And I'm like, girl, snap out the trance. What is happening here? And you see it a lot. And it's so how are you going to be able to pivot into an audit space if you can't talk to people that may make more coins than you? Got I mean, I don't know. I
Well,
can't.
this is the same with parenting. Children are out of control because for a good while, parents wanted to be their children's friends.
Good. Well, I think it's still there in some
Well,
instances.
no, that's what I'm saying. For a good while, they have wanted to be their children's friends. And So therefore, they don't want to give the necessary correction when it's needed. And that is what I see with all of these departments when it comes to providers. Like they're so busy trying to like I don't care that I have a doctor's cell phone number or a doctor calls me. Because first of all, they don't want to talk to me anyway. They wouldn't if they call me once, they would never call again. But I don't care about you being a friend. I don't because I don't come to work for friends. I come to work for money. And you are you and if part of my job means that I have to speak truth to power and call you on what you're not doing, then so be it. But you have a lot of people. In fact, most people don't ever do it. They want to talk to these people as if it's well, it would be nice if you did this, as opposed to uh, you need to do this because your documentation is out of order, and it's going to cause problems 2, 3, 4 years down the line because somebody else is going to look at this one day, and then what's going to happen because they don't understand. It's not about the money you get paid. It's about the money you keep,
Amen.
and they don't get that. The accountability and what gets paid today is not what you will keep tomorrow, and that's
Exactly.
what they don't
And we see
understand.
that in all of these cases. These cases aren't the ones that just happened today or last month or even last year. These cases go back because of this pattern. This person has developed a pattern that is going on and on and on. And then once it's detected and they're going to look at a certain number of claims, if it's determined based on the threshold and the percentage of errors, they're going to extrapolate that. They're going to take this. Oh, well, we see this is common, and this is something that you do. So we're going to extrapolate based on these percentages all the rest of these claims for this year and whatever, however many years they looking back. That's how you get those dollars into those millions of that's how you get those cases in the millions of dollars because they're saying, oh, look, nobody is taking and looking at all of them cases. They don't have to. We see your pattern. Your pattern is easily distinguished between what should happen and what you did. It's very easy. I don't know. This is this is why healthcare is the way it is. This is why
Well,
healthcare is the way it is.
now that we have this new Supreme Court ruling, it's about to. I think it's going to get muddier.
Uh uh uh.
I really
Yes.
do.
And we'll look at that next week. I think we can do that cross comparison. I feel like it's a series. Tune in next week to see what Chevron has to do as it relates to our
Look,
conversation this week and the conversation from last week.
look, and we need that sound from Law and Order. Dun dun.
Dun-dun.
Yeah.
Don't play. I'll be out here on AI trying to figure out a song. Get me as close to Law and Order as you possibly can without infringing on anybody's copyright. Oh, God. And she says the doctor's office being a soft audit and don't even know it. Spreadsheets full of denials is a clue. It's a mess. It is a mess. She said definitely not worth a free hotel jumpsuit and a pair of slides. Lord, it's the practice loss. If they lose a valuable educator, I would know my worth, respect my credentials, and dip. It's not worth it. Jail time. You're right. You're right. And again, that's where folks come in and whistle blow. To me, I think they leave this. It's ripe for the taking. Now, again, there has to be a lot of. It's up to the government to determine or discern whether or not it's a case that they want to follow. But if it's enough information and if it's enough um, evidence to support, then mm, and I guess if it's a big enough dollar amount, then that may be something that they would look into. I don't know. I just think it all just be so simple, right?
Could
Right,
be.
right, right. Could be Crazy, crazy, crazy. Okay, well, let's. So, did you know that by becoming a Patreon of ours, you're joining a community of individuals who share a deep appreciation for the intricacies of healthcare revenue cycle. Not even a more than a deep appreciation. I feel like there's a passion, and we're just really, really trying to get folks to understand that it could all be so simple. So here's what you can expect as a valued Patreon and a member of the Tea Sippers. Yes, yes. Exclusive healthcare insights so you gain access to in depth articles, webinars, and resources covering the latest healthcare trends, compliance updates, and revenue cycle best practices. Early access. Be the first to receive expert insights and guides, ensuring you stay ahead in the ever evolving healthcare industry. Personalized support. Enjoy direct access to our team of experts for guidance on medical coding, compliance issues, and revenue cycle management. We're here to answer your questions and support your professional growth. And community connection. You can't put a dollar sign on, or a dollar value on that. Join a private community of healthcare professionals where you can network, share experiences, and collaborate on finding solutions to common challenges, like telling folks they need to be responsible and accountable for their documentation. By supporting us on Patreon, you're not only advancing your healthcare knowledge and career, but also contributing to the collective and the success of the Tea Sippers and all of those of us working with Professional Reimbursement Network, LLC, in the Patreon. And we are all a resource that empowers healthcare professionals like you to thrive in their roles. So thank you for considering becoming a Patreon. Check out the link in the description of the video or patreon.com/Clarice Warner, the girl with the pearls. Um, your support means the world to us, and we look forward to helping you excel in the world of health information. All right, y'all. So we are definitely at the top of the hour. Thank you again for joining the Saturday morning tea. Was the tea spilled today? Or even if you were joining or checking out the replay, thank you as well. But was the tea spilled today? I saw a teacup earlier.
Yes.
Was the tea spilled today?
And
Put
then
the tea.
one more thing before we conclude this topic. Like whenever I hear about, whenever there's mention of clinical validation, I just really become concerned for coders because coders are, whenever there's, because now whenever they talk about clinical validation, they remove coders from it because just like we talked about last week, they say that clinical validation is beyond the scope of a coder. I don't know how it could be. I really don't. But they're just moving further and further away from coding and diminishing coding. And it's just, I think it's all just tying in line with ultimately what they want AI to do. But that's just I just think that this is a continuing erasure of the impact and the input from coding.
And to that point, this is a prime opportunity for coding associations to get together and be the voice and advocate for those in that profession. We know for years they've been a little silent, too silent, but silence no more. Take the muzzles off and start having some conversations with those who are in positions to hear and know and value and appreciate what these coders come to the table with.
Well, I just renewed my AHIMA membership like last week, so I got this survey from AHIMA
Hmm.
about something about membership. When I tell you, I let it rip. I hope a couple people read it.
And the one thing I can say about and I'm gonna call it the new AHIMA, one thing I can say is they do read the information. They take uh, the data from any evaluations they have at heart. They have people who are actually is I don't think it's AI read. I think people are actually putting their eyes on it, and then when they see enough of the information, they're pushing it up the chain, and then you hear back, okay, we've heard from the people that da 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 da. So that is one of the things I do appreciate, that I feel they are listening, and I'll because my world has been AHIMA these last couple of years. more than AAPC. I know that that's what is happening over on the HEMA side. I would hope that the same thing is happening over on the AAP side as well. All right, y'all. All right, all right. So, again, if this message was valuable for you, help us share the message, or this, if this information was valuable for you, help us share this message with others by sharing the video and subscribing to the channel, Professional Reimbursement Network. Be sure to follow us for more information on all things health information, compliance, revenue cycle, and medical coding. And as you leave out, don't forget to hit the thumbs up or like button. Also, check out the Coding Nurse channel on YouTube. So this has been a great session today. For those of you who are tea sippers, we will see you in the meeting after the meeting at 10:15. So in a few minutes. Mr. Jesse, do you have any additional last comments?
Uh,
Okay.
great episode as always.
Yes, and stay tuned, doom doom, for next week as we add more to this puzzle. So thank you for joining, and remember, be safe, be kind, and don't wish for it, work for it. Make it a great weekend, and until next time, take care. Bye.